Hello everyone. Good morning, good afternoon, good evening, wherever you're joining us from, and welcome back to the GUcast studio. We are thrilled to bring you the next PCF ProsTIC webinar. I'm Dr Renu Eapen, urologist at the MacCallum Cancer Centre here in Melbourne. This is a great collaboration between the US Prostate Cancer Foundation, ProsTIC, the Prostate Imaging and Theranostics Centre of Excellence here in Melbourne, and the International Cancer Imaging Society. And I am thrilled to be joined by my co-host for this webinar, the legendary Professor Michael Hofman, a nuclear medicine physician and director of ProsTIC. Welcome back, Michael.
Thanks, Renu, and thanks for co-hosting.
You know, every time I welcome you back to the GUcast studio, I'm reminded of the fact that you were our very first guest on the podcast.
Very special.
And we discussed pro-PSMA, and look how far we've come since then.
We have got to thank COVID for that.
So today we have a really multidisciplinary panel. I'm a urologist, you're a nuclear medicine physician, but we're missing a medical oncologist.
I think we should get one.
We should get one, and your wish is our command because we have Dr Louise Kostos, a medical oncologist from Peter Mac here joining us. Welcome, Louise.
Thanks, Renu. Perfect timing.
Louise is doing a PhD with ProsTIC and is really the secret behind many of our clinical trials, LuCab, Violet, Alphabet. Most of those protocols were written by Louise and co.
Secrets exposed.
Yeah.
So it's going to be a great webinar this time. A huge panel joining us, and we'll introduce everyone gradually. But I think we should introduce our main guest for the event.
The main guest? Who's that? There's so many.
She's flying solo today, but it's a pleasure to welcome Dr. Andrea Miyahira to this webinar from the Prostate Cancer Foundation. Andrea, good to have you join us.
Well, thank you, Renu, and the Peter Mac team for putting this wonderful webinar together. So I'm Andrea Miyahira, here representing PCF. I'm the Senior Director of Global Research and Scientific Communications. I just wanted to say a few words about PCF and ProsTIC. PCF has been funding PSMA and theranostics research for 30 years. It's been very exciting just to see these past few years, the field is finally blossoming with Buteau, PSMA PET, and many other new theranostics targets that are now under investigation. To date, PCF has funded over $60 million on theranostics research, mostly on PSMA, and now we're looking at new targets as well. This includes the establishment of ProsTIC at the Peter Mac. We've been so proud to see the accomplishment of this team, leading critical theranostics trials and educational initiatives like these global webinars and the in-person preceptorships. In 2022, we also established a tactical award program, and an international team led by Michael was awarded one of these to develop new lead-based alpha particle radioligand therapies, targeting a range of new targets. So we're very excited about this. Anyway, I'm excited to learn from our colleagues on the call today, and especially about how theranostics is being practiced across Asia.
Thank you, Andrea. I mean, it's amazing the outreach that the PCF has, and it's been such a leader in so many of the innovations that have occurred in theranostics over the last few years.
Yeah, we've had incredible support from PCF, and you've really helped accelerate the Peter Mac program, so we're very grateful. For those online, we are going to make this interactive, so there is a Q&A button at the bottom of your Zoom webinar interface, and you can type in a question, such as Declan, who asked, would you like to be a urologist? And you can upvote other people's questions, and that's how we'll prioritise the questions that we answer. We've also pre-prepared a few questions that will get your votes on. The theme of today's webinar is bringing lutetium PSMA earlier. I think we're trying to bring it from a last line to a first line treatment. And we have an incredible number of registrants. We've done it in a different time zone. Usually we get up at 5 a.m. to do this for a European American time zone. This is much better, Renu, don't you think?
It really is, isn't it?
1 p.m. It's lunchtime in Australia.
Yeah.
So we have 1,000 plus registrants from 67 countries, and it is a different distribution than our previous webinars because of this time. So you can see the first three actually had over 50, and number 3 is Korea. I think we had like 80 registrants from Korea, followed by India, Pakistan, Taiwan. So we have got lots of people from around Asia, which is fantastic. And we've introduced all our Asian panel members after our keynote speakers.
Absolutely.
Here's a map, and you can see there is a good concentration in Asia. And this is what people associated themselves with, mainly nuclear medicine physicians and specialists, followed by industry.
Louise, I would have thought more medical oncologists would have registered.
I know, I'm not sure what's happened there. I think we're all just too busy in the middle of clinic seeing patients.
We've got more nurses than medical oncologists. And I think
dedicated to the job.
If we compare this to previous webinars, the standout to me is the rise in nurses joining, over almost 50 registered, and consumers and patients.
It is also important to note, although it's excellent to have the consumers participating in these webinars, we can't provide any personalised medical information, so patients should speak to their doctors if they do have any specific questions.
But it's great that there is so much interest from such a multidisciplinary audience.
Great. Let's go.
Shall we kick off?
We might kick off.
All right. So our first speaker for this webinar is Professor Louise Emmett. She's a nuclear medicine physician and Director of Theranostics at St Vincent's Hospital in Sydney. And she's going to tell us about the Enza-P trial, which is looking at the synergistic effects with a combination of enzalutamide and lutetium PSMA. So Louise, over to you. Thank you.
Wonderful. Well, thanks so much for having me on the webinar, and great to be able to talk about Enza-P. So Enza-P is a phase 2 randomised trial, theranostics trial, pre-chemotherapy in the metastatic castrate-resistant space that was run by ANZUP Clinical Trials at 15 centres across Australia, and has currently had an interim readout with an overall survival readout to be due later this year. It's looking at enzalutamide alone versus enzalutamide plus lutetium PSMA in MCRPC, pre-chemo. So we know that both lutetium PSMA 617 and enzalutamide improve overall survival in prostate cancer and metastatic prostate cancer. But when you look, if you could just pass to the next slide, Michael. Oh, that'd be great. So when you look in the PREVAIL trial, which is enzalutamide pre-chemotherapy for metastatic castrate-resistant prostate cancer, there's a significant proportion of patients that fell quite early, even though we know it's a very active agent. So the rationale or the idea of Enza-P was to see if we could add lutetium PSMA to enzalutamide, with enzalutamide being the key treatment as an adjunct extra therapy, to see if it actually improved outcomes in these patients with poor risk disease. We know from previous work that we've done that you do get this really nice interaction between the androgen receptor and the PSMA receptor in the prostate cancer cell. And in MCRPC, you actually get this upregulation of PSMA when you add an ARSI. So the idea of Enza-P is that you have different clonal populations which will have different sensitivities, some to ARSI, some to lutetium PSMA. The nice thing about when you start enzalutamide with metastatic castrate-resistant prostate cancer, you actually get upregulation of PSMA expression in some cells, particularly those androgen-resistant cells. We need very bright PSMA activity in order to get good treatment response with PSMA-targeted agents. So if we make them brighter, we get better cell kills. We get left with a cell population that's lower PSMA expression, likely to respond to ARSI for longer. So that's the rationale of Enza-P. The rationale of Enza-P is that you get left with this clonal population that will respond to ARSIs for longer with the use of lutetium. So Enza-P, the eligibility was metastatic castrate-resistant prostate cancer, pre-chemotherapy with a rising PSA and 2 risk factors for early treatment failure on enzalutamide alone. Needed to have a positive PSMA PET. And primary endpoint was PSA progression-free survival, with other progression-free survival and overall survival and health-related quality of life key other endpoints. Patients were randomized 1-to-1 to either enzalutamide or enzalutamide plus, either 2 or 4 doses of lutetium PSMA. So looking at the screening criteria, it was just a PSMA PET. We didn't use diagnostic CT or FDG, and had a very simple enrollment screening criteria with an SUV max of 15 at a single site and 10 at all sites of measurable disease. And then patients needed 2 risk factors for early treatment failure on enzalutamide alone. We used adaptive dosing with the Enza-P trial, and there was a lot of imaging undertaken within the trial itself. So all patients got a baseline PSMA PET for screening, They had a translational PSMA PET at day 15 after commencing enzalutamide. And then on the experimental arm, 2 doses of lutetium PSMA with SPECT CT undertaken at each time point. And then all patients on both arms had a day 92 PSMA PET CT and the interim PET. For the experimental arm, this was used to determine whether a patient did or did not get an extra 2 doses of lutetium PSMA. In this case, the patient had no residual disease on their day 92 PSMA PET, so they did not get further doses of lutetium PSMA. They just continued on enzalutamide. This patient had, so their baseline day 15 PET, first 2 doses of SPECT, and then on their day 92 PSMA PET scan, you can see they had residual disease. So this patient went on and got another 2 doses of lutetium PSMA based on residual disease on the interim PET. All patients also had PSMA and FDG PET at first progression, whether that was radiographic or PSA progression. So we have at this interim analysis that's been presented, we had 220 patients who were screened, 162 patients randomized, 79 to enzalutamide and 83 to the combination. There was an 18% screen failure rate. And at the time of this interim analysis, 16 patients remained on trial on the enzalutamide alone arm and 32 patients on the combination arm. Looking at the adaptive dosing, 81% of patients received all 4 doses of lutetium PSMA, and median follow-up at the time of this presentation is 20 months. So the primary endpoint was PSA progression-free survival, and that was strongly positive with a hazard ratio of 0.43. So 7.8-month progression-free survival for enzalutamide and 13 months for enzalutamide plus lutetium PSMA. When we look at radiographic progression-free survival, the hazard ratio was 0.67, and it was 12 months progression-free survival for enzalutamide and 16 months for enzalutamide plus lutetium PSMA. We did have a problem with RPFS, so we had a large number of patients on the enzalutamide alone arm who were censored on this analysis because they came off trial after first progression and didn't get confirmation on the CT and the bone scan. And I think this is a really important part of Enza-P, an unexpected side effect of having lots of PSMA PET built into the trial itself. We ran into problems with radiographic progression-free survival. It's probably not very interpretable. PSA 50% response rate was much deeper with the combination, 93% compared to 68%. And 90% PSA response rates were 37% for enzalutamide and 78% with the combination. So in summary, this is the first randomized trial combining an ARSI, enzalutamide, with lutetium PSMA 617. It provides strong evidence for enhanced anti-cancer activity on its primary endpoint, PSA progression-free survival, 7.8 versus 13 months. It's an active life-prolonging treatment for the control group, which I think is important. It is the first trial that uses adaptive dosing of lutetium PSMA based on an interim PSMA PET. And I think this is a really nice way to give lutetium PSMA. It has the potential to reduce toxicity by only administering if we have persistent PSMA-avid disease present. And I think this is going to be important as we move it earlier. We only gave 2 or 4 doses, but 2 to 6 doses would probably further improve progression-free survival if we're going to do it again. There is planned follow-up of progression-free and overall survival. The cut is at July 2024, and we will have survival data later this year. And there is an extensive embedded translational imaging liquid biopsy program for biomarker analysis, and that is funded as part of a PCF Challenge Award. So thanks so much for PCF. That's going to be really interesting to look at. And you can see here the translational component here. We have multiple PETs at serial time points with CTC, so circulating tumour cells, which were sent living cells sent directly to Singapore and then the US as they were drawn, and ctDNA. So we're going to get a lot of information to come. Thank you. And just thanking everyone involved in the trial, particularly Enza-P, CTC, and Movember.
Thanks so much, Louise. As always, that was an excellent presentation. And I think the Enza-P trial really answers so many questions. First of all, can we use lutetium PSMA earlier in the castrate resistance space, but also is there a role for combination therapies, which I'm sure we'll talk about later on in the webinar. I just wanted to remind everyone we will go through any questions after all of the presentations. So please feel free to put any questions in the chat if you do have any, or we can have a discussion once the presentations are finished. I'd like to welcome Professor Kong as our next speaker. Professor Kong is a clinician scientist as well as a professor and director of radiology in Singapore, and she'll speak briefly about the International Cancer Imaging Society conference happening this year in Singapore, which she is co-host of. So welcome, Professor Kong.
Thank you so much. On behalf of the ICIS, thank you for this opportunity to co-host, and thank you for this airtime. So shall I share the slides myself, or?
Yeah, I think that'll work best, actually.
Okay, I'll do that. Okay. Right, so, oops. Somehow runs on its own. Interesting. Maybe I'll just do this then.
That looks good if you just go to your full screen mode.
Yeah, but it tends to have its life of its own. I'll just do this on the full screen mode. Anyway, I'm delighted as president of the ICIS to welcome you to Singapore for the 23rd edition of the ICIS. And it will be held on the 27th to the 29th of September in the Shangri-La Hotel in Singapore. And it's the ICIS annual teaching course, as I said, is on the 23rd edition, and we've organized course in various countries through the years. Predominantly it's in London and in Europe. And 2 years ago, it was first held in the USA, and this year it will be the first time in Asia that we will be hosting the ICIS annual teaching course. Also different from previous years is that this will be a joint conference together with the Singapore Radiological Society and the College of Radiologists in Singapore. So the meeting will have a focus on cancer imaging, but also be comprehensive, covering other aspects of radiology, including interventional radiology and allied health groups. So the ICIS is exists to advance imaging in multidisciplinary management of cancer by promoting education in oncological imaging. And the theme for the 2024 meeting is Illuminating Cancer Care. And we will aim to highlight the evolving role of imaging and intervention in modern clinical practice. And in our content of our program, we have 3 keynotes, 3 plenary sessions. So the 3 keynotes will cover multi-omics of diagnosis and management, raise the issues of our global oncology workforce challenges, and then a global topic about outreach to LMICs. The plenaries will, in the theme of the meeting, cover illuminating precision oncology. And you would recognize one of the speakers in this plenary session, none other than Dr. Michael Hofman. And then we will have another plenary on cancer biomarkers and integrated diagnostics. And the third one on digital oncology and AI for augmenting patient care. I just want to highlight also that we will, apart from these, we will have educational talks, scientific sessions, and hands-on workshops. So there will be one on prostate cancer that will be conducted by Professor Anwar Padani. So we are outreaching to participants. I think for many of you, it might just be a stone throw away. We are outreaching to diagnostic interventional radiologists, medical oncologists, radiation oncologists, nuclear medicine physicians, of course, as we will also cover molecular imaging and theranostics, scientists, students, and our allied health professionals. So I look forward to welcoming you to Singapore for the ICIS. We will have our early bird registration and abstract open on the 28th of February to coincide with the ECR. And our website will be simply ICIS-SGCR-WIAS, which will be officially launched then. And this is our International Cancer Imaging Society website. So thank you very much for that time. And I hope to see you, many of you in Singapore soon in September. Thank you.
Fantastic. Thank you, Professor Kong. That was a great summary, and it looks like it's shaping up to a great meeting. So hopefully lots of people will join, and we certainly do encourage everyone to try and attend in Singapore at the Shangri-La.
It's a really great teaching course. There's not a lot of radiology, nuclear medicine meetings that are focused on cancer imaging. Often if you've got a radiology meeting, you'll get musculoskeletal, stroke, a bit of everything. But to focus on cancer imaging's actually really important. I think it's a unmet need in an imaging meeting, and ICIS has really been pivotal over the last few decades of having that as a specialty within imaging.
Thank you. Thank you so much, Michael and Renee. Thank you.
All right, we are flying through.
Next up, we have Professor Oliver Sartor. Now, Oliver is a medical oncologist, but really an honorary nuclear medicine physician. He needs no introduction. I think he's led really most of the phase 3 industry large trials, all the way from the Alsimca trial of radium-223, probably even earlier ones that you'll tell us about that I'm not even aware of, Oliver, all the way through to the Vision trial, which has led to global approval and availability of Pluvicto. And Oliver is going to give us a summary of the findings of the PSMAfore trial, which was presented at ESMO last year. Oliver, are you able to share your screen for the slides? And if you can't,
Sure.
I can do it on my side, but it may work better if you do it on your side and then just...
Well, let's try it on
progress
this
through.
side and see what it looks like. And so let's see. I am hopefully beginning to share
You are. If you just go
right
slideshow
now.
and start the slideshow,
And
I think
I'm
that'll
going
be
to
perfect.
put it on slideshow here in just a moment. From the beginning, how does that look?
Brilliant.
Fire away.
Okay. First of all, thank you, Michael, and for all your colleagues at PDMAC. And thank you to PCF, because PCF just makes so many things possible. It was rather interesting to hear they've been funding PSMA research for 30 years. I think that's pretty remarkable. What we have here is a little bit of an opportunity to look at the PSMA 617 lutetium earlier in the treatment paradigm. And I'm going to be presenting some data that was initially presented at the Presidential Symposium in Madrid. And whenever, it's me talking, there are so many others who have contributed. And I don't need to call them all out by name, but I'm simply going to say Novartis was the sponsor. They really put it together. It is a global series of investigators, a really widespread steering committee. A lot of expertise goes into a phase 3. My privilege to be able to present to you this evening. Now, what is PSMAfore? So PSMAfore, phase 3, randomized, again, lutetium-177, PSMA-617, versus an ARPI change, that's androgen receptor pathway inhibitor, taxane-naive patients with PSMA-positive metastatic CRPC. Now, I don't want to go through all the details on the eligibility, but let's just say we use vision criteria for selecting the patients by PSMA. The randomization was 1-to-1, and crossover was allowed once you encountered the blinded independent central review, or PFS endpoint. So BICR, blinded independent central review, was absolutely critical, and crossover is absolutely critical when interpreting this trial. Now, primary endpoint, rPFS. Well, I thought it was sort of interesting that Louise, in her beautiful slides, presented a hazard ratio of 0.43, so I might as well do the same. Here we got 0.43 again. By the way, it's the second interim analysis, actually. The median was 12.02 months, and that's in the lutetium arm, versus 5.59 in the RP switch arm. And clearly you can see those confidence intervals don't even come close to overlapping. And I'll simply say this is very statistically significant, not necessarily a surprise. Now, the radiographic response rates, this is RECIST criteria. So not everybody's looked at, only those people with measurable disease. And if you add up the complete responses, which are about 21%, and the partial responses, you get a little over 50% on objective response. I think that's really good. That compares to about 14.9% in the control arm. Now, PSA waterfall plots, it's good and bad news here. Clearly, you can see that the lutetium on the left-hand side is better than the control group, but confirmed decrease is 57.6%. Goodness gracious, that may pale in comparison to Enza-P, 93% in the intent to treat. Now, there's a lot of differences. It's not just the utilization of enzalutamide in the lutetium arm. There's also a little bit of a difference that all of our patients were pre-treated with an ARPI, whereas in hers, that wasn't necessarily true. Nevertheless, we see clear distinctions in the lutetium and the control group. Now, we do have an overall survival analysis to present, but it's relatively immature. Hazard ratio 1.16. That's more than 1. You want to see it less than 1. But I do want to point out a very important fact. 84% of the patients who were eligible for crossover actually did. That's enormously high. 84% went from the control arm to the lutetium. So this is not necessarily ever going to be positive for survival with that degree of crossover. The median OS of about 19 months in each arm is pretty immature. Look at the events. There are only 69 events in the lutetium arm, 65 events in the RP change arm, and that's only about 29 or 28% of the actual number of patients enrolled on the trial. I think we have to conclude this is a pretty early look at overall survival, and we shouldn't make a lot of conclusions, but remember that crossover of 84%. Now, one of the things that was interesting is we looked at those bad treatment emergent adverse events, grade 3, 4, the serious adverse events. And guess what? Lower in the lutetium arm than in the hormonal arm. I think this was stunningly safe. If you look at dose adjustments, 3.5% of the patients enrolled on lutetium had a dose adjustment as compared to 15% on the hormonal arm. That's, again, pretty striking. Discontinuation rate's about the same at 5.7%. Good safety, bottom line, very good safety. Now, let's go earlier for a second with the PSMA addition study design. And this is hormone-sensitive prostate cancer. So this trial has completed accrual. We don't have any results yet. And basically, it's metastatic hormone-sensitive prostate cancer randomized to standard of care. In this case, standard of care means ADT and an RP, plus lutetium or minus lutetium. Primary radiographic progression-free survival, primary endpoint with a crossover on RPFS. And then, of course, long-term follow-up. So no data on this, but the theme is moving the lutetium earlier. Well, here's an example of that. Now, this is a trial that I'm a little bit enamored with, and that's because we're going to try to do lutetium in a phase 3 trial, hormone-sensitive, but no hormonal therapy. We're going to try to avoid castration. The name of the trial is PSMA DC. DC means delayed castration. So these are patients with PSMA PET-positive disease, but negative conventional imaging. All the lesions have to be amenable to SBRT. We're going to take up to 5 lesions. Has to be metastatic, by the way. PSA doubling time of less than or equal to 10 months. And all of these patients are previously pre-treated with a radical or radiation therapy to remove the prostate from being an issue. Non-castrate T at baseline, randomized between SBRT plus or minus lutetium. Primary endpoint, MFS conventional imaging, that is metastatic-free survival conventional imaging. That is an FDA approvable endpoint. If we get this done, it's a positive trial, this will really change practice. So I'm hoping that it might be true. So what's the optimal time for PSMA radioligand therapy? Number one, I think when you provide clinically meaningful improvements as compared to a standard of care, that's a good way to think about it. But we really need to concentrate on getting a regulatory approval based on those endpoints. And that way, the results can really change practice. If we get the FDA and the regulators to be able to say thumbs up, that's when things really change. I think it's also interesting and important to think about reasonable alternatives to the castration and chemotherapy paradigm that our patients just don't like. I think it's time for us to do better. So let's give it some good thought. Thank you very much, Michael, for the opportunity to present today.
Oliver, you can stop sharing your screen. That was a fantastic talk, and I like your concluding insights. We might throw to an audience question. We get the first poll up. Louise Kostos has put this question together, so I'm going to let her ask it. So you'll see a question on your screen. You don't have to answer it. If you don't feel you have the knowledge to answer it, don't click, but if you feel you can, then go for it.
Yeah, so I think it's really interesting. Each country has different ways of accessing lutetium PSMA, and therefore it does seem to be sequenced differently depending on where you're living. So we thought it'd be interesting for people to vote based on your local practice. Where would you normally sequence lutetium PSMA for your patients? Is it normally as per vision, after a taxane and at least one novel hormonal agent? Like therapy, so prior to cabazitaxel, but after docetaxel and an NHA, or before a taxane, like in the PSMAfore study, or is there anyone out there doing it prior to first-line novel hormonal agent or docetaxel?
Thanks, Louise. We do have about 450 people online, which is pretty cool.
It's incredible, isn't it?
And, you know, about 20% have voted. So I think that's a good number. We might end the poll and see what the answer is. Most people are 60% are using it
as per vision.
Post carbazitaxel, 34% prior to carbazitaxel, which is kind of our practice now. Peter Mac, would you say?
Yeah, I'd say I think that's also reassuring because globally, cabazitaxel generally does have low uptake, at least in the public healthcare sector. I think many patients, I think under 30% actually are exposed to cabazitaxel. So I guess it's reassuring that it appears clinicians are still considering cabazitaxel for patients, and certainly that's our practice locally at Peter Mac.
Now we do want to throw to our expert panel.
Absolutely.
Around Asia. We might introduce them one by one and throw them questions.
Okay.
We might start with Singapore, Dr. Suping Tang, who's a senior nuclear medicine physician at Singapore General Hospital, spent time at Peter Mac as a therapy fellow some years ago, back when we were doing our phase 2 very first trial and treated some of the first patients, probably in Australia or even globally, with lutetium PSMA. What's the current practice in Singapore? When do you choose to use lutetium?
Thanks, Micah, for having me here today. I think in Singapore, it is mostly after ARPI, but not necessarily after chemotherapy. We started this treatment right after we have learned this from you and your team from Peter Mac in 2017. And as of today, we have treated around 200 over patients, delivered 800 over cycles. We did a short and some analysis of some of our patients sometime last year, and around 40% of our patients are actually chemo naive. Although our multivariate analysis does not show that these patients who are chemo naive do have a better outcome compared to those the other arm. But individual patients experience some of the longest survivor patients at our center are chemo naive, basically.
Yeah, I think it will be really fascinating to look at the subgroup analysis of SPLASH, looking at the taxane naive patients. SPLASH is another trial we're yet to see the final results of, looking at giving lutetium PSMA earlier on, and also the final results of the PSMAfore study patients who are taxane naive, but certainly it seems like at least before docetaxel, but after a novel hormonal agent seems to be very promising and likely will be the new standard of care, depending on, you know, the readout of all of these important trials.
Shall we do another question?
We should.
Yep.
Another poll, you mean?
Another poll. We might launch the
Yeah.
poll. This one's about
How do patients...
Yes, that's a good one.
Yeah, so access is really interesting in Australia because we currently do not have widespread access. We're very lucky at Peter Mac. Patients can come here and access lutetium PSMA on a compassionate access program or clinical trials, and there are other centres becoming available where patients can self-fund lutetium, but we're interested to see in your country, generally, how do patients access lutetium PSMA? Is it self-funding trials? Is it reimbursed already, either by insurance or by the government?
and it looks like there's a good split of about a quarter. I might just share these results. They should now pop up on your screen. I didn't do that last time, and you can see it's actually about an equal split. And I guess this probably varies from country to country. And if we could poll everyone on our panel, we'd probably find within each country it's kind of a majority on trial or a majority self-funding. But there are some parts of the world, like India, where lutetium PSMA has been available for really a very, very long time, and patients have flown there from all parts of the world, sometimes to access lutetium, a bit like flying to Germany in the early days. So I wonder if we cross to Professor Balanger Singh, who is from the PGMUR in Chandigarh. I had the pleasure of going to the Indian Society of Nuclear Medicine meeting about 12 years ago now. He's the ex-president of the Society of Nuclear Medicine in India. Are you able to tell us about what's the current access of lutetium PSMA throughout India? Can you give us a bit of a feel for that?
Oh, Baljinder, you're just muted there.
You can just unmute yourself.
Yes, sorry.
Bottom left.
There we
Perfect.
go.
We can hear you now.
Yeah, thank you, Michael. Michael, I think you have been a very frequent visitor to India starting from 2010, and then second Theranostic World Congress in Chandigarh. And as you requested me to present the current theranostic practices in India, I think your question is now supply of lutetium and PSMA in India. So we have indigenously produced lutetium produced by our national agency, the BRC, Bhabha Atomic Research Center, and some of the centers in India also depend on the import of lutetium PSMA. I think India is doing good. We have been into lutetium PSMA therapy more than a decade, and many new centers are coming up now and practicing these, cutting-edge therapies. But since India is a huge country, I think since many people are not covered by insurance, I think Indian government is taking a significant lead into setting up a dedicated nuclear reactor for clinically useful alpha and beta emitters. I think with this coming in, I think we will expand further the theranostic practices. But looking at the size of the patient, volume of the patient requiring these therapies, I think we need to catch up with the rest of the world by escalating our indigenous production of these cutting-edge therapies.
We love having visitors from India to Peter Mac, and one of the amazing things is when people come out from India and see some of the things we do, within a few months they're doing it back in their institution, whereas in other countries sometimes they look at what we do and they go, well, we can't do that.
There we go. Innovator. All right, so we'll move on to Professor Yao Zhu, a good friend of ours at GUcast. Zhu is an attending urologist at the Fudan Cancer Centre in Shanghai, has a great interest in prostate cancer theranostics in particular, and previously attended our Peter Mac preceptorship and will be attending the ProsTIC preceptorship in March. and he's led many investigator-initiated trials. Zhu, what's the situation back home in Shanghai? When do you sequence lutetium PSMA treatment? Is it after AR-targeted therapies and before chemo or after chemo? What's the axis like there?
Hi, Renu. Thanks for having me. In Shanghai, we have most of the lutetium PSMA performed in the clinical trial setting, and our patients mostly enrolled those patients post-chemo and post-ARSI. But we do see some patients who have very nice response before the chemotherapy. So nowadays, our center is also a center performing the PSMAfore study. So we are trying to move this kind of the treatment before the chemotherapy, and the patients can have nice performance status and a nice response and a high quality of life.
Fantastic. And what is the funding like for lutetium PSMA over there?
Yeah, I think most like 80% of patients are enrolled in a clinical trial setting, and 20% of patients may have self-funded in mainland of China.
I think another really interesting question that we don't really have a definite answer to at the moment, and really depends on how patients are accessing the treatment, is how many cycles would you normally give? Because I guess the PSMAfore study, there were 6 cycles of lutetium, whereas Enza-P, there's a more adaptive dosing approach where patients have 2 cycles and possibly a couple more depending on their response. So what would be the standard number of cycles that you would normally give in your country?
Yeah, so what I learned from our nuclear radiologists is they are trying to give 4 to 6 cycles in our patients. And it's really depend on the response and the patient's adverse events after this kind of treatment.
Yeah, Zhu is a true urologist / nuclear medicine physician.
Fantastic.
Nuclear urologist.
I'm launching another question.
Yeah.
Another poll.
Yeah, another poll. What percentage of patients are eligible for lutetium PSMA? Because medical oncologists, nuclear medicine specialists, radiation oncologists, everyone uses a different threshold. I think it's fair to say that the strongest evidence base is from the VISION trial, which uses a gallium-68 PSMA PET, and they had a threshold above liver, and also used a contrast-enhanced CT. And if there were no lesions on the CT that didn't have PSMA uptake, then you were suitable. And then we ran our own therapy trial. We had a slightly different threshold, an SUV max over 20, and we used FDG PET as well. But here the question is, what percentage of patients are suitable in your practice or in your country based on whatever threshold you use? Just a gut feel, more than 90%, 70 to 90, or less than 70. What's your feel for Peter Mac? What's our number about at the moment?
I think we're still generally following more the therapy eligibility. So we still screen patients with the PSMA as well as FDG PET scan. And generally we're looking for an SUV max of at least 20. So I think I'd say about 25% patients aren't eligible based on imaging, are not eligible.
Yeah, so around 75 are eligible. I think that's about right. And if we look at the poll results, which I will share, that's actually the majority, although there's a big split here, 14% say over 90%. That's a bit more VISION-like, or PSMAfore-like actually. 50% 70 to 90, and in 40% less than 70%. That's actually, that's a little bit surprising.
Yeah, because I'd say at Peter Mac, we follow quite strict criteria compared to other studies such as VISION. So I would have thought our screen fail rate or ineligibility rate would probably be the highest.
We might take that opportunity to shoot to Taiwan. I had the pleasure of going to the Taiwanese meeting last year for the first time, and I met a lot of urologists, nuclear medicine physicians, and medical oncologists. It was fantastic. So we invited Dr. Yuyi Huang to join the panel. She's a nuclear medicine physician in Taiwan, and her husband's a medical oncologist. What a good partnership, right?
Excellent.
And into GU medical oncology, even better. Well, and I think you are sort of leading access to lutetium PSMA in Taiwan at the moment. Can you give us a summary of the state of play at the moment?
Okay, thank you, Matt. Thank you, Peter. Thank you, Michael. We have started the lutetium PSMA treatment since last year, 2022. And we got a few patient experience because it's not reimbursed in Taiwan. So we have 15 patients and undergoing like 34 cycles in our institution. And for the screening of the PSMA treatment, we take like vision criteria. So we probably have over 90% of patients would be eligible for this treatment. And specifically, we have a lot of old age patients, and they are not suitable for chemotherapy. So most of our patients are chemo naive, and some of them are really severe in the late stage. So about half of them cannot make all the 4 to 6 cycles of treatment. So we got like 30% of patients who can finish over 4 or more cycles of lutetium PSMA treatment, and 70% of them got this patient got a very good PSA response and good quality of life. So I think the situation is some kind of different in Taiwan because we treat most of our patients are very late stage. So we still hope we can do that treatment earlier in the disease status, and not that like now we are doing very late stage patients. So that's our experience here.
I just wonder, from Oliver Sartor in the USA at the moment, given the regulatory approval, which is vision-like, which is post-docetaxel, if you have a elderly patient who's simply not suitable for docetaxel, not suitable for carbazitaxel, but highly suitable for lutetium, are you able to access Pluvicto for that patient, given that they're medically unsuitable for chemotherapy? Or is there a regulatory problem that because it's not approved in that setting, you simply cannot access it?
Yeah, Michael, it's kind of interesting. It's not a regulatory issue as much as reimbursement issue. So in the United States, the regulators drive the reimbursement almost completely. So if you have an insurance company and you're trying to practice out of the scope of the regulations, and they're going to be encountering a $42,000 per dose expense, then most insurance companies say not only no, they say hell no. And intermittently, you might be able to get one through, but as a rule, the insurance companies follow the regulators, and the insurance companies are designed to save money when they can. That's what they want to do. Us, we want to treat patients. So we're always knocking heads. We don't always agree with the insurance companies, but they have their rules and they follow them. And I'll simply say it's a problem.
Great. We have another question for the panel, and it's around FDG.
Yeah, so I guess as I mentioned in PDMAC, we are using FDG to select patients, and those who have clear discordant disease generally, we don't recommend that they proceed with lutetium PSMA, but obviously in trials such as Vision, just a CT was used rather than an FDG PET. And I know in Australia, at least, it's not reimbursed for this indication. We have an access program at PDMAC, but that's quite unique. So we wanted to, I guess, put the question out there and ask, in your practice, is anyone routinely using FDG PET, or is it really just based on PSMA PET?
And here are the results. I think most people using it some of the time, 20% most of the time, 21% all of the time. I like that answer. And 16% never.
Yep.
Again, a huge mix.
Yeah, I mean, this is a point of great shock when you travel around and you hear other people's experience, because access to PSMA PET is not uniform around the world. And here we are doing a PSMA PET and an FDG PET in order to give this treatment. But when you think about it, so a significant number of patients are self-funding this treatment. So it really is important to make sure that patients are going to benefit from it.
yeah, I think if we look at variation in outcomes, it's mostly driven by patient selection. Perhaps as we move this treatment earlier and earlier, we need better and we need more patient selection rather than less. So if we have 90% suitable for vision, if we bring it through to first line, it's my belief that if we want to have successful trials, we probably need to be a bit more selective, because if you've got low PSMA expression, you're probably not going to do well compared to some standard of care such as docetaxel, even if you don't like chemotherapy. So you're really going to have to select patients and personalised treatment a little bit more. I know Louise Emmett has some strong thoughts on this. Louise, do you want to comment on that?
So we're talking about personalising treatment with adaptive dosing, both to intensify and to de-intensify treatment. And, you know, I think this idea of biomarker-guided treatment, where you've been doing it for years, Michael, we all have, because we do the SPECT and we do, some people do interim PET. But I do think we'll get better responses than we will just giving 6 doses 6 weekly without any imaging at all. But definitely we need to show that in trial.
I'd like to throw to another panel member from Korea, Professor Ilham Lim. He's director of the Nuclear Medicine Department at the Korean Cancer Centre and also president of the Theranostics Research Group of the Korean Society of Nuclear Medicine. Good to know they have a Theranostics committee. And he's done some fascinating work. Can you give us an update on maybe state of play in Korea, access to PSMA theranostics at the moment?
Yes, thank you for having me. I'd like to summarize the status of the Korea of the PSMA treatment. For the lutetium, it is now the Pluvicto is not approved in Korea yet. However, in Korea there are two companies of the radiopharmaceutical companies. So we are doing in South Korea. It is now in the stage of the phase 2 clinical trials, and also it shows also very nice treatment response. So hopefully in near future, I also expect to probably they will be approved by the Korean FDA. And another issue is one of the problem is the Korea FDA is a little bit shows some tight regulation for the kind of some radiopharmaceuticals. So in South Korea, it is not allowed to produce in kind of some homebrew radiopharmaceuticals. So it is not possible to making our own. Although in the technology of the nuclear medicine in South Korea is quite enough to do that things, but so that is one of the hurdle we need to overcome in this situation.
Yeah, I like that homebrew of pharmaceuticals. What's our homebrew at PSMA?
Well, we've got a question on it. Which PSMA ligand is most accessible for patient treatment in your practice or country? And it's PSMA 617, which is marketed by Novartis' Pluvicto, PSMA INT, of which there's a few different formulations from some commercial companies in the US, but also available as homebrew, a little bit like the coffee we have in the morning. Actinium-225, lots of interest in alpha. I think, Ilham, you're doing some great work with alphas in Korea, and maybe some medical oncologists just refer for PSMA and they don't even know what the difference is, or if there is a difference. And it probably varies a lot according to regulatory approval. So this is a really interesting question, and the results are also very interesting. I'll end the poll. There's about 100 people that voted on that, and 70% use Pluvicto, which actually surprises me because I know that's the dominant answer in the USA, where Pluvicto is registered, approved, and now reimbursed, and also in our centre at Peter Mac, where we use predominantly PSMA 617, thanks to access from Novartis. But around Asia, I know there's a lot of INT in use in India and Singapore and other countries. So given this Asian focus, I thought we'd see a lot more INT use. But in fact, we don't. And no one answered actinium. So people aren't using actinium first line, which is good.
So, it's interesting. At ASCO GU, I don't know, Michael, if you heard, there was a talk about how beta emitters are in fact not the best agent for treating micrometastases, and in fact, something like actinium or radium would be better. What are your thoughts on that?
We might segue to a panel member from Japan.
Let's do
got
that.
some expertise in really novel alpha emitters, I think. Professor Seigo Kinua
Kanazawa?
from Kanazawa.
Yeah.
Unfortunately, there's been a very bad earthquake in Japan a few weeks ago.
At the start of January.
And we were sorry to hear that you were really personally affected by that. So we really send all our condolences to people who were affected. I think there were many deaths in Japan, and even your house had a lot of damage, I think. So firstly, just acknowledging the challenging times and thank you for joining in this challenging time.
Yeah, it's good for me. And as Michael already told you that the Japanese people number of Japanese people are killed by the earthquake. And then now it's a stage for the restoring the damaged areas just close to Kanazawa, my place. Anyway, my friends and my families are all okay, and then we are peacefully living now. And I think I got a very tough question from your side. And perhaps the Japanese community, I mean Osaka University, friends in Osaka are trying to use actinium-211 along with PSMA. And the clinical trial is going to start, let's say, in few months, I guess. And then the reason why the Japanese community is keen to actinium-211 is the difficulty to obtaining the actinium-225 in my country. Anyway, Osaka and Fukushima University also has actinium, not actinium, astatine-211. And then now the Japanese community is thinking to build a kind of big accelerator to get more amount of astatine-211. So the way of Japanese people are just a little bit different from the way in the world. However, of course, the Japanese researchers and Japanese doctors are looking for the actinium-225 for the breast cancer. So I would say we are just watching what will go on for the distribution of actinium-225 in the world.
Fantastic.
Japan has really been a leader in nuclear medicine in the 80s and 90s with evolution of PET. There are more cyclotrons in Japan than most other countries, and actually many more PET scanners than most other countries. And a lot of the pioneering work early in PET has been done in Japan. So we look forward to seeing your new accelerator and being formed, and maybe you can lead the world in alpha and astatine and some really novel nuclear medicine approaches. Before we go to the audience Q&A, Renu, there's one more panel member from Vietnam, a more developing country that we haven't introduced. That's Dr. Son, known as Alex to us. He came and visited us in Peter Mac for a few months, and I had the pleasure to visit his centre in Ho Chi Minh. And again, when he came to visit us at Peter Mac a few years ago, we were doing PSMA PET CTs, and he took that back and I think established maybe the first gallium-68 generator in Vietnam, and is now doing PSMA PET. So I'm pleased that PSMA PET's now available in Vietnam. Can you give us a bit of a feel for access to both PSMA PET and also to PSMA therapy in Vietnam today?
Thank you for inviting me. I'm happy to be here and sharing our status. Actually, Vietnam is a developing country, so we meet many problems with funding and also administrative process. In our country now, that's only PSMA gallium-68 for diagnostic was approved in Ho Chi Minh City, Choi Hospital, since December 2023. So just 2 months ago. About PSMA therapy, it's still be quite far for future because of funding and also because of many documentative process. We need to overcome it. So in my hospital, actually, we already have a generator, also module synthesis for PSMA and also DOTA-TET. We also submit documents to the hospital and health administrators, but we need to wait for the approval. So our solutions for some issues are maybe strengthen our relationship and try to catch up the trend of theranostics in over the world, and also call the funding for research and also maybe clinical trial from government and also IEA. So
I think there are tremendous opportunities in Vietnam and throughout Asia. Going to Vietnam, it's really an eye-opener, really accelerating very quickly.
And we might move to some of the questions coming through.
Just before we do,
a little
advertorial.
Oh, yes, we need
for ProsTIC 24.
Absolutely. Yeah, it's coming up. It's every 2 years, and this is our second one. And it's shaping up to be a fantastic meeting. We've got Ken Herman as our special guest, amongst other incredible guests.
We have a lot of overseas invited speakers listed here. I won't go through them all, including Mike Sategi from South Africa, who's recently published a big paper on actinium PSMA in Lancet Oncology, and many other people. This is really a teaching course. It's 2 days. First day is focused on PSMA imaging, and then the second day on PSMA therapy. And there's still time to register, so go to prostic24.org. It's being held outside of Peter Mac in a hotel that's recently been renovated that has conferences facilities. So it's going to be a great visit to Melbourne as well for those who do want to come. There is still time to register. I think we have over 250 people registered already, but there is room for more.
So that's coming up in mid-March, 14th to 16th of March.
And it's in person only. We're not going to do virtual like this. We want a face-to-face.
Oh, so if you don't attend, you miss out.
Now to questions.
Yeah, so thanks to everyone who sent through some questions. We'll start working through the list. So the first one from Alan White is about using PSMA, lutetium PSMA even earlier. So not even in the hormone sensitive space, but before the prostate's even been removed, so the locally advanced setting. And wondering if this is a potential approach. And I might ask our expert on this topic, Dr Renu Eapen.
This question's from Alan White, who's a great friend of the podcast. So hello, Alan, and thank you for joining us, and thanks for the question. Yes, so we recently published the lutectomy trial, which is the earliest use of lutetium PSMA in the upfront setting prior to radical prostatectomy in men with high-risk localized prostate cancer. And again, we used a PSMA SUV max cutoff of 20. And we really were looking at dosimetry, so how much dose of radiation we could actually get into tumors expressing PSMA. And it was about 20 gray to the prostate itself, a median dose, and a median dose of almost 38 gray to the lymph nodes. You know, it was a phase 1 trial, so it was really looking at the safety of the treatment as well. And, you know, lutetium PSMA was tolerated very well, 1 to 2 cycles prior to surgery. And for us surgeons, one of the real pressure points here was how difficult would the prostatectomy be after lutetium PSMA, and we were pleasantly surprised to see that it really didn't make it that much more difficult. I mean, these are advanced cases anyway, but it didn't add much in terms of difficulty. So really interesting trial. And I think one of the most interesting aspects of it will be some of the translational work we do. I mean, we're using a lot of lutetium PSMA, but we don't really know how it affects the prostate cancer tumor microenvironment, which is traditionally thought to be a very cold environment. So how these treatments actually work and whether they have an effect on systemic immunity is yet to be seen. So I think some of this work will be really interesting.
So Oliver said earlier that, you know, patients don't like ADT, hormone treatment, and they don't like chemotherapy. So we need to move the envelope earlier. But patients don't like prostatectomies either, do they?
They love it.
Oh, they do.
They do.
But do you see this as a possible replacement in the future? Declan Murphy did a great talk on surgical obsolescence. It's on GU Cast. I would recommend that episode. I think I remember it's set on Noosa Beach. It's a fantastic episode. Do you think one day you might use this instead?
Oh, look, that's a difficult question to answer. And I think, you know, we need more trials to know for sure. I think at this point in time, we really can't say that. I mean, the surgery is still here to stay, but I think a synergistic effect would be really interesting.
You'll be the nuclear surgeons.
We already are, Jane.
Speaking of treatment side effects, I think there was a question about darolutamide, which is generally better tolerated than enzalutamide, and whether we'd see the same effect, the same synergism with lutetium PSMA. So I might direct that to you, Louise. Do you think that the clonal expansion you discussed is a class effect for novel hormonal agents, or is it something specific to enzalutamide?
No, so there's definitely publications in abiraterone as well that show that you get the same effect. So I would say it's a class effect. And I agree, running the Enza-P trial, enzalutamide causes mild cognitive impairment in a proportion of patients. It causes significant fatigue in about 15% of patients. And a lot of those other ARSIs are actually better tolerated. So I think it's a class effect.
Thanks, Louise.
We might just go to the questions that have the highest upvotes and then work down the list.
Good. Yeah. Is this the top one?
The top one is from an anonymous attendee. Do we let anonymous people ask questions? We do.
We do. We do.
Would you recommend F18 PSMA PET to assess eligibility for lutetium as opposed to gallium-68? And if you're using F18, is the liver uptake a problem, high versus low? Some have suggested using the spleen. How do you deem suitability? Maybe that's
a good question.
To answer that question. Maybe
anyone from our panel?
How about Su Ping? Can you answer that question? Gallium versus fluorine?
Yeah. So in Singapore, we don't have the fluorine. So it's mainly gallium PSMA 11. So I mean, I do understand why the question was asked, because for some fluorine PSMA precursors such as 1007, is predominantly excreted by the liver. So whether you can use that as a threshold for eligibility criteria for treatment, I mean, I don't really know the answer, but I would think for fluorine 18 DCF-PYL, that would be okay because it's fairly comparable with the gallium version of PSMA 11.
Oliver Sartor, I wonder if you can answer. I know when Pluvicto was approved, there was some controversy because the FDA approval was really linked to the gallium-68, but many places are using DCF-PYL. Oliver, in the US, is DCF-PYL acceptable to insurance companies, or are some rejecting that?
It is. It's initially, Michael, there was some pushback, but right now we have what we call the NCCN guidelines, pretty sensitive one. Let me draw the distinction between gallium-68 and F18 with regards to the ligand, because PSMA 11, DCF-PYL were fine. 1007 is a different beast, and there it is not analogous. And so 1007, you cannot use the same threshold because of the liver uptake. So bottom line, depends on the ligand, but in the US, DCF-PYL, F18, and gallium-68, PSMA 11, all the same.
I think that's an important update. One, I don't like hearing F18 versus gallium-68 because we really need more detail. There's multiple F18 ligands. Yep. And actually we use both at PeterMac, both DCF-PyL and gallium-68, and we think they're really very equivalent. And in fact, since we've done so many of both over the last 10 years, we did a paper in patients that had had both traces. Maybe they had DCF-PyL to start with, and they came back and had a gallium, and we compared the physiologic uptake, and it was pretty much identical between the two traces. And this was actually a fellow project, and it's cited in the NCCN guidelines to support the use of DCF-PyL for selection of Pluvicto. So very proud of that little paper.
Speaking of different ligands, when we think about the different PSMA ligands, there's another question for you, Oliver, with regards to some of the PSMA monoclonal antibody ligands available, such as J591. And I guess the question is, what are your thoughts about using either lutetium or actinium combined with these monoclonal antibodies for microscopic disease in prostate cancer following stereotactic radiotherapy?
Yeah, so that's a very specific question about post-SBRT, and I think that alphas are likely to be a little better. You know, if you look at the crossfire required with a beta, it really is not optimal for single cells or very small cell clusters. I think the alpha is going to be better than the beta in that small sort of microscopic disease setting, but let's be very careful. We don't really know without the experiment having been done. And the question started off with J591 and antibodies, and then it ended up with SBRT. And there might be more than one way to look at this. And I think we're going to need to prove that the antibodies really work in a randomized trial. We got a little bit here, a little bit there, but no definitive studies. We need definitive studies to be able to draw conclusions.
There's another question on the role of SBRT, referring to the other to your study where it's in the standard of care arm. And the question is, well, is SABR a standard of care for oligometastatic disease?
Well, it's a great question. I think it's a standard of care. I don't necessarily think that there is the standard of care. There's some people who prefer hormones. There's some people who don't. I think if you talk to patients, they often prefer not to be treated with the hormones. So I think it is a standard of care, but it's not necessarily the standard of care. By the way, it was acceptable to the FDA. This has gone through the FDA. So I'll simply say, we'll let others decide. In the end, if we have a positive trial, I think it'll be very popular.
And another question for you, Oliver. You're very popular. Most of the questions are directed towards you. You'll be pleased to know. The question is whether in that study you need to be M1 positive on conventional imaging, or can it be defined on the PSMA PET CT?
No, the eligibility criteria is very, very clear. Let's start with the endpoint. MFS conventional imaging endpoint. That means you can have no conventional imaging metastases at baseline. You need to transition from one state to another. So to get in the trial, PSMA PET, conventional imaging negative. Progression is conventional imaging positive. Metastatic disease, prostate cancer working group 3. So that's what allows the FDA approval to occur, because we're transitioning into a new state. And MFS, conventional imaging, is an approvable endpoint. No doubt about it.
There's a question from Mauritius.
Okay, let's hear it.
They're about to submit a theranostics project to the public health system, and they would like to know, where can they get their lutetium PSMA from?
Where can they get their brew? Yeah, their home brew.
It's a good question. We've got Dr. Buteau here. We haven't
introduced Dr. James Buteau, who's been here, and James is a nuclear medicine physician at PeterMac. He's a PCF young investigator. James, do you have some spare home brew to spare?
Actually, I have some in our garage. So it depends. Yeah, we can have a chat. I guess wherever you can get it, good to have a few contacts in case there are, we have Isotopia in Israel, for example. We get some from Ansto. We have several different nuclear reactors across the world that you can source it from, and always good to have a bit of redundancy to avoid any logistic issues and, delaying treatments for patients.
What are some of the challenges with importing lutetium PSMA?
Importing and exporting. Yeah, I mean, I guess we've had some quite interesting challenges just with the terbium-161. Comes all across from Israel, sent to the States, sent back to Israel, sent to Australia. So I think that just getting through customs, having some good contacts that can help fly it through a lot more seamlessly. That's probably one of the key issues to getting it there on time for the patients.
Actually, now that you do mention terbium, you should give us a quick update on the Violet trial, because I mean that's a very cool trial, and we've treated some of the first patients in the world.
It is, yeah, the first almost 30 patients. So it's a very interesting trial. I think it does touch on micrometastases. So you do have micrometastases that are energy sheltered from normal lutetium PSMA. So when you get down to those last few cells, most of it travels, 50, 90 prostate cancer cells in diameter. Terbium-161 is a bit like an enhanced version of lutetium. It's like setting off these deadly firecrackers in the prostate cancer cells. So you can really hit those little micromets, and hopefully this will lead to more durable responses.
So this is my nuclear medicine physician coming out. This is the beta emitter, and it emits Auger electrons,
yes,
correct?
Auger and conversion as well.
I learned that at the ProsTIC preceptorship. Fantastic, James. Thank you. Another little advert, the APCCC.
Welcome and hello to all the participants of ProsTIC. We really hope to see you also in beautiful Lugano for APCCC 2024, end of April. And our radios will tell you who will be there and what we will be talking about.
You can see in the background the map that shows where all the experts for APCCC 2024 will come from. But APCCC is also open for all participants, not restricted only to the experts. And we will target everything from locally advanced prostate cancer to the very advanced stages. And of course, we will discuss a lot about PSMA for diagnostics and treatment.
So hope to see you all there, and see you soon.
See you soon. Thank you.
That's at the end of April in beautiful Lugano in Switzerland. It's, in my opinion, probably the best prostate cancer meeting. Second to the PCF meeting only. So there's still time to register. It's the 25th to the 27th of April, I believe. And several of the people here today are panelists for the APCCC. And a lot of the difficult questions will be answered.
It's a really good meeting because a panel puts together around 100 questions, but these are not simple questions. These are controversial questions, areas of uncertainty, areas where there is no clinical guideline that is definitive, because a trial hasn't been done to answer the question, because you can't do a phase 3 trial answering every question. So it may be, would you give lutetium PSMA to someone with a GFR of 30 mils per minute? And then they take votes from an expert panel, and if over, I think, 70% of the panel vote in favour of one answer, then there's deemed to be a consensus, and that forms then a manuscript which has these consensus guidelines. So I think it's very valuable for all these tricky questions, but the conference itself is fantastic.
We might go back to the questions. So
a few more questions.
There's a few more questions for you, Oliver. So a couple of people have actually asked about the PSMAfore study and the current overall survival data. I know it's immature at the moment, but as you said, over 80% of patients did cross over, which is likely impacting on the overall survival results so far. But the hazard ratio does cross 1. So what are your thoughts on why that is? And I suppose, is there anything you think could have been done differently with the trial? And I guess, is there anything, I guess, any caveats, or how would you like to explain the overall survival if it does end up not being significant when we do have an RPFS benefit?
Yeah, so a couple of questions intertwined there. So number one is, we do have a crossover adjusted overall survival analysis presented at Madrid. I just left it off. That's 0.80. So that does go the right way, number one. Number two, I think confidence intervals really need to be taken seriously. Medians are actually point estimates. And if we look at that 1.16, that is a point estimate. with some pretty damn big confidence intervals built around it. So as we get a little more maturity, I think we're going to end up having smaller confidence intervals. It may drift back into a more favorable less than 1 range. I don't know, or maybe it'll just end up right around 1. But I think that's the consequence of the crossover. Now, one question I think that is legitimate, and this is a question I've been posed here and there, is there the potential for harm to occur to lutetium-treated patients after the protocol is completed? We looked at the adverse event rate. It's fabulous. It really is. But what about downstream effects? What about harming chemotherapy in the future? Maybe the patients can't get their docetaxel, cabazitaxel at the same dose and schedule that they would have without the lutetium. That could have an impact. I'll simply say, immature data, big confidence intervals. Let's look at it with a more mature analysis. I'll tell you my opinion when I know a little more, and it won't be that much longer. Unfortunately, these patients are expiring because of the lack of effective therapies. Underlining a critical issue. We need better therapies for this disease. Metastatic castrate-resistant prostate cancer, it's fatal.
Now, there's been a lot of other questions in the chat. I don't think we're going to get to them all. And there's also a lot on Enza-P, and Louise Emmett's been kind enough to be tapping away, actually answering them in the chat, so we can try and save those and share them.
Absolutely. And we should actually go back to, before we wrap up, we should go back to Andrea and see if she has any closing words before we thank everyone.
I just want to say thank you again to the Peter Mac team and to all the panelists. I learned so much, and I think it's such a great thing to see ProsTIC, doing such international efforts. We all want to see, these therapies being used appropriately all over the world. So thank you again, and I look forward to hearing about the preceptorship.
Fantastic. Thank you, Andrea, for joining us. And it's a shame that Howard Sol couldn't make it. I think this might be the first PCF ProsTIC webinar that is missed, but we've certainly missed him, and we send him our best.
And also a big thank you to Declan Murphy, who's, you can't see it because he's hiding in the shadows in the room. Maybe if we turn the cameras somehow, we can see him on the edge. But he's been there he is. He's been controlling all the whiz-bang equipment. I don't know how he does it, but I suppose it's not that much different than robotic surgery.
So if you do want to check back on any of this content, we will be posting this as a special GUcast episode. So in the next few days, it'll be out. So please do have a listen. Please subscribe, rate us, like us, send us your suggestions and feedback.
Thanks to all the panel members from around Asia for joining.
What a fantastic group we had.
And thanks to the International Cancer Imaging Society for co-hosting. Don't forget the ICIS meeting in Singapore.
Absolutely. And a special thanks also to Oliver Sartor and Louise Emmett for their fantastic talks today.
And Louise and James in the studio.
And thank you, Michael. It's been great.
It's been wonderful. We'll have to do it again.
And see you next time for another webinar. Thanks, everyone.
Thank you.